Today, we'll be talking about the clinical features, diagnosis, and management of cystic fibrosis. So, cystic fibrosis is a multi-systemic disease that affects not only the lungs, which is what people commonly think about with CF, but also the pancreas, the liver, and the intestine. So, mechanistically, in CF, thick secretions build up within the tubular structures of different organs. So, for example, in the lungs, the bronchioles accumulate these thick secretions, which leads to impaired respiratory function and frequent infections. Similarly, with the exocrine pancreatic ducts, these are the ducts that transmit the enzymes that are important in digestion from the pancreas to the small intestine. Those can get blocked as well, and patients end up with pancreatic insufficiency. And also in the small intestine, this can manifest as a Meconium ileus in newborns, which we'll talk about in a little bit. CF is due to recessive variants in the gene CFTR, which encodes a chloride transporter. And CF is a fairly common genetic condition with a birth prevalence of about 1 in 2,500 individuals of European descent. Now, we'll talk about the clinical features of CF first in newborns and then in children and adults. So, in newborns, mainly the features of CF are related to the GI tract. So, that's in contrast to the pulmonary symptoms that we often think about with CF. So, just keep that in mind that infants with CF typically will not present with respiratory symptoms. They'll instead present with GI symptoms. And so, what are these symptoms? Well, starting prenatally, you can see echogenic bowel, which we have a picture here on the right, is essentially showing up as bright. That's the definition of echogenic. You can see the fetus here, the face, the head is over here, the diaphragm separating the heart and the thorax from the abdominal cavity. And then you have this bowel here showed by the arrow that is brighter than the surrounding tissue. And that's echogenic bowel seen in cystic fibrosis. The fetus can also present with dilated bowel loops or an absent gallbladder that can all be seen on a prenatal ultrasound. Now, one of the most common presentations of CF in the neonatal period is what's called failure to thrive. So patients essentially will not be growing well. They'll have short stature, and they'll also won't be able to gain weight. And this is in part because of the exocrine pancreatic dysfunction. If you can't digest your proteins and your fats properly because you're missing those pancreatic enzymes, you're not going to grow well. Meconium ileus, we're going to talk about on the next slide. We have a picture because this is one of the life-threatening emergencies that is associated with CF, and so very important to know about. Some parents report a salty taste when they kiss their baby in a baby who has CF. So important to keep that in mind. Remember, CF is due to a disorder of chloride transport. And so sodium chloride is essentially salt. And so that's what builds up in the skin of newborn babies and also older children and adults due to that defect in transporting chloride. Also importantly, some newborns don't have any symptoms at all. And so they may not show up until later in infancy or even as a toddler, or potentially even later. So, and lastly, again, just to reemphasize, the lung symptoms tend to appear later in infancy or childhood, or even sometimes in adults. But you're not going to see typically a newborn or a neonate with pulmonary symptoms like, cough, frequent respiratory infections. Typically, that's a little later on in life. Okay. Next, we'll talk about Meconium ileus, which is that complication I mentioned. Essentially, you want to think about Meconium ileus whenever you have a newborn with abdominal distension and bilious vomiting. So they are vomiting bile and they're vomiting whatever they've eaten that day as well. So essentially, this is due to an obstruction at the ileum, which is the terminal end of the small intestine. It's essentially where the small intestine connects to the large intestine. So if you have a block there, you'll end up with Meconium ileus, and this is very common because of the thick secretions that are present in the small intestine in cystic fibrosis. You essentially get an obstruction at the distal ileum, resulting in Meconium ileus. Now, if you were to take an X-ray, as is shown here, of the infant's abdomen, you would see a dilated small bowel. So that's what you see here, sort of in the darker region. You see that that bowel is dilated, and you can also see a microcolon. So that's because the feces is not able to pass from the small intestine through the colon, and so that microcolon is also shown here in the lighter color. You can see that there. Now, also important to note, most cases of Meconium ileus are due to CF. So very important to know that if you have an infant with Meconium ileus, you want to go ahead and test them for cystic fibrosis. The opposite is not true. Not all infants with CF present with Meconium ileus, but just good to know that association. I also want to contrast Meconium ileus with pyloric stenosis, which presents typically in a 2 to 3 week old with non-bilious vomiting, not bilious, but non-bilious vomiting. And that does not have a well-established genetic etiology, but it's good to know about because both can present with significant vomiting and both are emergencies that need to be treated potentially surgically right away to save the life of the infant or newborn. Now, children and adults tend to have slightly different set of symptoms. Many of them overlap, but the disease is predominated by pulmonary symptoms in kids and adults. So you have cough, bronchitis, and respiratory infections. And important to note that the pulmonary manifestations are the #1 cause of death in most patients with cystic fibrosis. Patients can also have nasal polyps, so important to know that. And then pancreatic insufficiency, and this isn't just limited to the neonatal period. You can also see it in children and older adults. And indeed, people with CF tend to have short stature, so they tend to be shorter than normal. They don't gain weight well, and that's due to that pancreatic insufficiency. Also importantly, once you're of reproductive age, you want to make sure these patients are counseled about the possibility of infertility, particularly males, due to what's called congenital absence of the vas deferens. So the testes are able to produce sperm, functional sperm. However, the sperm isn't able to traverse where it needs to go because the vas deferens are absent. And so important to know about that association. Most males with CF will have congenital absence of the vas deferens. So currently in the US, all 50 states screen for CF as part of the newborn screening. And the way that these states screen for it, at least initially, is via something called immunoreactive trypsinogen. And so trypsinogen is a precursor pancreatic enzyme to trypsin, which is a protein that digests other proteins. So it helps break down proteins into amino acids. And so, again, produced by the exocrine pancreas. So if you have a blockage of your exocrine pancreatic ducts, the trypsinogen can't get out, can't make its way into the small intestine. And so instead, it backs up into the bloodstream. And that's where you get an elevated trypsinogen level. And that is what is screened for on newborn screen, particularly on the dried blood spots that are collected from the heel pricks of infants at day 1 or 2 of life. Now, if this is positive, the next step depends on the state, but oftentimes it will include some combination of DNA testing as well as a sweat chloride test. Now, these are diagnostic tests, not screening tests. And so you can make the diagnosis with the combination of these two tests, the DNA test as well as the sweat chloride. Again, why are we testing sweat chloride? Well, again, CFTR is a chloride channel, right? So you're going to have abnormalities of how chloride is transported across membranes. And so it makes sense that we'd want to test the sweat chloride in infants who we suspect have cystic fibrosis. And again, the follow-up protocols will vary depending on the state. So some might go straight to DNA, some might want a repeat trypsinogen level. It just depends. Most of the time in most states, they will send a targeted CFTR variant panel. So what is this? Essentially, they're collections of variants that are common in the population and that cause most cases, not all, but most cases of CF. So most babies with CF will be able to get a diagnosis with these panels. And why would the states prefer to use these panels and not, say, single gene CFTR sequencing? Well, typically the panels are quicker and they're cheaper. So just in terms of throughput, if you're screening many babies, it's easier, it's better to have a test that comes back sooner and that costs the state less. So that's why the states prefer this. However, one very important caveat to remember is that you can have false negatives. So you can miss patients with CF if you're using the targeted panel, and particularly if those patients are ethnic minorities who tend to not have the same variants that are represented on these variant panels that most states use. Right? And these variant panels are based off of folks of European ancestry. And just to show you, this is a map of the United States. And what we can see is that each state is colored by the number of variants that are included on the CFTR panel that is part of the follow-up newborn screening protocol for that state. What we can see is that the number of CFTR variants varies a lot between states. So from anywhere between one variant, so the Delta F508 variant, all the way to, and that's in Mississippi, all the way to over 100 variants in a variety of states. So depending where you're born, if you're born with CF, you might have a better chance of having it detected right away, just based on which state you're born in. Next, I just wanted to mention the association between the CFTR genotype and phenotype. So broadly speaking, the variants in CFTR are divided into 6 classes, which you can see here along the top. Each of those classes corresponds to a particular type of mistake or functional error that's present in the CFTR gene and protein. So for example, in class 1, you're essentially not producing any protein, either because you don't have mRNA or you don't have a functional protein. And the relevance of this is that if you look at the bottom row here, the clinical features tend to be more severe with those genotypes where you completely lose function. That could either be due to a truncating variant or to a deletion, as you see here in the specific mutation examples. And then in contrast, the missense variant, so if you have a missense variant, tends to be less severe. You don't completely lose function of the CFTR transporter. And so you maybe have some residual function, and that corresponds to less severe disease. But it's really difficult to predict exactly what symptoms a patient's going to have based on their genotype. Even in the same family, 2 siblings, both with the same genotype, can have very different clinical pictures. So just illustrating some general principles here. The other thing I want to highlight is that for many of these variants, there are medications that are available, and some of those medications are listed here. These are oral medications taken by mouth, and in many cases, they are transformative. So these are real game changers for patients. They can prevent complications related to the lungs and the pancreas, and they can extend lifespan and also prevent against the need for a lung transplant. So to discuss a little bit more about management, I've just talked about the oral CFTR modulators. So these are those small molecules that are targeted to specific CFTR genotypes. For pulmonary symptoms, chest physiotherapy and mucolytics are indicated to loosen the mucus and help prevent those infections and the buildup of mucus that can impede respiratory function. Now, antibiotics can also be given prophylactically, particularly to young children, to prevent lung and other infections. Pancreatic enzyme replacement therapy is very important as well because most patients with CF are pancreatic insufficient and need that pancreatic enzyme to grow. Patients might also need more calories than is typical because of the pancreatic enzyme deficiency and also potentially because of the increased work of breathing due to the abnormal lung function. You want to consider in vitro fertilization with surgical extraction of sperm. So you can actually microaspirate sperm from the testes, which again produce sperm. The issue is with the transit of sperm. And so essentially, once you extract the sperm, you can perform IVF and those individuals can have a successful pregnancy. Okay, so fortunately, there are many excellent resources, both for people affected with CF as well as their healthcare providers. I've listed only a small subset of those references and resources here, but I hope you have time to explore them. If you found this video useful, please like, subscribe, and share. Also, consider subscribing to my weekly newsletter with board-style questions for genetics exams. And you can also buy me a coffee to show your support for this channel. Thank you.